let's start with our next symposium, number 10, which is about non-alcoholic fatty liver disease. We all are well aware of that, how important is this disease, and this pandemic non-communicable disease is affecting every corner of the world. So we have a great panel of experts. They are talking about various challenging aspects in the field of non-alcoholic fatty liver disease. Let me to introduce you first with our chairs. Our chairs includes Professor Altaf Alam. Professor Altaf Alam is a very renowned gastroenterologist and professor of gastroenterology. He's a teacher of teachers and mentor of many, including me. We have Dr. Faisal Wasim Ismail is a consultant gastroenterologist from Khan University Hospital. Professor Amjad Salamat from Quaid-e-Azam University Hospital, Islamabad, Pakistan. Professor Bikaram, he's from Sindh, and Professor Akif Dilshad from Lahore General Hospital, Punjab. We have Professor Nasirullah from Sindh Institute of Urology and Transplantation. So, ladies and gentlemen, let's move to our first talk, which is about a very burning topic, which is NAFLD, or redefining NAFLD to MAFLD. Is this a precise approach or not? This is a very debating topic, and we are honored to have Professor Ajay Kumar Duseja. Professor Ajay Kumar Duseja is a head of the Department of Hepatology, Postgraduate Institute of Medical Education and Research, Chandigarh, India. Professor Ajay has a huge profile, and he is a part of a Asian task force working on non-alcoholic fatty liver disease. So, Professor Ajay, thank you very much, and you can start your presentation. Okay.
Good evening, everyone. Am I audible and visible?
Yes, you're audible, and we can see you as well.
Thank you so much. And so at the very outset, my sincere thanks to Professor Abbas and Dr. Amna Subhan and the other members of the organizing committee for giving me this opportunity to be part of faculty for this 14th annual meeting of PSSLD. I think let me now first share my screen. Just a minute. Can you see my slides?
Yes, we can see your slides.
Okay, thank you. So it's very nice to be, as I said, get connected, even though virtually. So the job I have been assigned is to answer this question, redefining NAFLD to MAFLD, is it plausible? I think we as scientists, whether as clinicians or, as basic scientists, we know that science is a dynamic process. And there have been some changes in nomenclature in medicine and in hepatology in particular. We know the story of PBC, autoimmune hepatitis. So whenever we're looking for a change in nomenclature, it should be for good. So good for understanding the disease, good for the medical community, good for our patients, good for the society, and there has to be a wider consensus. Okay, there was some background noise. Okay. Now, when I've been asked to answer this question, redefining whether it's plausible or possible, my answer to this is a little provocative. And this is because I think a few months back, I think Professor Zobair-M had written this commentary that this is a little premature to change. And we had also written a commentary on his article saying that it is not only premature, but also confusing to rename NAFLD as MAFLD. So my thinking, again, in the last few months has always been the same. I'll try to see my point in next, 15 minutes or so. But then we have the world leaders with us. I think Professor Younossi is there, Professor Saniyal is there, and others. So I think we can have some discussion at the end. So let me start with the basics. I understand that probably there are some postgraduates also who are attending this meeting. So when we say NAFLD or non-alcoholic fatty liver disease, we know that fatty liver disease is there for, many, many years, but the definition of, or the exact entity of NASH came around 40 years back when Ludwig gave that, entity, looking at the, slides of some of the non-alcoholic patients, which were mimicking, alcoholic hepatitis. And then the umbrella term of NAFLD came somewhere in 1986. And this is applicable both to adults and children. And when we say NAFLD, we mean that there is hepatic steatosis, which is, defined either by imaging or histology. And we have to exclude secondary causes of fatty liver, and the predominant obviously is alcohol, medications, and various others. Also, we understand that when we say NAFLD, I think this is very closely associated with metabolic risk factors, and people do consider it as a hepatic manifestation of metabolic syndrome. Also, if you look at the spectrum of this NAFLD, within this it has what we call the NAFL, earlier also called as simple steatosis. Then it can progress on to NASH, which is thought to be the progressive form, and which can lead on to NASH cirrhosis and even NASH HCC. And when we look at the histology of NASH, I think there are various scores, and commonly what we follow are the NAFLD activity score and the steatosis activity and fibrosis score. This is all given by the ASLD. Whereas the new terminology, MAFLD, which is coming up now and which has been suggested by some experts now, what they mean is that this is applicable first is only to adults. If you demonstrate hepatic steatosis either on imaging or blood markers or on histology, and if somebody has overweight or obesity by the whatever criteria you're using, Asian or the Caucasian, depending upon the population, and or you have diabetes, you straightway become MAFLD. But if none of these two are present, then out of these 7 metabolic dysfunction criteria, you need to have 2 or more. And these 7, 4 are again the components of metabolic syndrome. And the other 3 which they have added are, one is the pre-diabetes, other is HOMA, and the last is the CRP. So this is what they are saying MAFLD as. Now the question comes is that why are expert group asking for this name change? So there are various reasons which they think are probably the name should be changed. And the first is they say that NAFLD is very, very heterogeneous and one size can't fit all. It can't explain everything what is happening in fatty liver disease. Also, they say that this is a negative definition. It's a diagnosis of exclusion. You have to exclude, alcohol and various other causes. And for MAFLD, alcohol and other etiologies can coexist. No exclusions are required. Then they also have a problem with this term called non-alcoholic. Why do they say that? Non, they are saying, because it's a non which is attached there, they are saying it is reducing the significance of the disease, trivializing the disease. Also, since it is alcohol attached there, they said that it is causing stigma to, the patients and society, that there's an alcohol attached to this. And secondly, in this definition, as I said, there's no mention about metabolic risk factors, and it is so closely associated with that. Also, the expert group feels that if you change this name, this will be good for the patients, society, hepatologists, non-hepatologists, and funding and the regulatory agencies and the policymakers. Now, let's see whether, how far they are right, and I'll just, share with you my thinking on all these issues. So they're saying NAFLD is heterogeneous. But we know even if you change the name to MAFLD, the heterogeneity will stay. Why I'm saying this is because there's so many drivers for this disease. It's a multi-hit kind of, pathways which are involved. Metabolic health is only a component which comes in the pathophysiology. We know the age, gender, ethnicity, diet, physical activity, so many things would be involved in the pathophysiology. Other than that, I think the genetics, epigenetics we know are involved. Professor Bajaj is going to talk about microbiota. I think we know that is involved there. So there were so many things. So even if you put the name as MAFLD, that will only explain a component of it, and then they are saying it will require different subtypes. So it will not explain, will not make it homogeneous. Secondly, the metabolic syndrome or the metabolic risk factors from which they're trying to define this MAFLD now is not present in everyone. And it varies from, again, race to race, population to population, that what percentage of people would have, metabolic syndrome. For example, in India, I think the northern part of India, where I come from, Chandigarh, is the capital of Punjab. I think we see a lot of people with fatty liver disease who have metabolic risk factors. They have metabolic syndrome. But this is one study I have picked up from the eastern part of India, which is close to West Bengal. This is from Orissa. And if you look at this, 336 patients, 50% of them did not have insulin resistance. And when they looked at the metabolic syndrome features in them, a quarter of them did not have insulin resistance, and not even a single component of metabolic syndrome. So what would you call this group of patients? Those who do not have insulin resistance, do not have any metabolic risk factors, can they really fit into MAFLD? No. Okay. Even if you look at the recent data, and this is the enhanced data which has been analyzed based on the MAFLD, so around 13,000 patients, 7,000 and 7.5 did not have fatty liver disease. Around 4,000 fitted into both MAFLD and NAFLD, which means the prevalence, whether you looked at from the MAFLD definition or by NAFLD, was almost the same. So then they found a group, which is a small group of 5%, which did not have any metabolic risk factor, but still had fatty liver disease. So they are calling it as non-MAFLD NAFLD. So I think this is little, getting confusing. So non-MAFLD, so you can have a NAFLD, non-MAFLD, so no metabolic risk factor, still fatty liver disease is there. And we also understand that the fatty liver disease in many people can just start without any metabolic dysfunction, and we understand that the fat in the liver per se can lead on to hepatic insulin resistance by, protein kinase C and various other molecular pathways, JNK and NF-kappa beta and all. And the metabolic dysfunction may or may not come later. So in the beginning, it could just be fatty liver without any metabolic dysfunction. So I think this is the one point which I wanted to make. The others are the other issues which we are saying about this. Let's start with another issue, which they are saying is it is the NAFLD is kind of trivializing the disease, or it is giving lesser importance to the disease because there's a non which is attached to this. But I feel non is probably not an issue. There are so many negative definitions in medicine, and for example, if you start, health per se is a negative definition. When we say healthy, it's an absence of illness or injury. This is an Oxford definition. Disease is a negative definition, absence of ease. There's so many other diseases in medicine, say non-communicable diseases, a larger chunk, non-Hodgkin lymphoma, non-cirrhotic portal fibrosis. So there's a non attached to this. Are these diseases less significant? Are we kind of trivializing all these diseases? I mean, my thinking is slightly different. So then comes the stigma. You're saying that there's an alcohol attached to it, so there's a stigma. I don't think that's an issue either, because we are calling them as non-alcoholic. Rather, the patients would be happy that their disease is not alcohol-related. It's non-alcoholic. And as I said, this is MAFLD is not applicable to the children where the stigma of alcohol may sometimes come in. So I think that's another issue. Lastly, then they're saying is about, the coexistence of alcohol and this. Yes, that is really possible in clinical practice. We do see patients have metabolic syndrome, have fatty liver disease. They do consume alcohol. Now they're saying is if somebody is consuming mild to moderate alcohol, I think it could still be MAFLD. But how about those who are heavy drinkers? They have, alcohol-related, say, severe alcoholic hepatitis, alcoholic cirrhosis, alcoholic HCC, right? And if they have had fatty liver in the past, they may take an excuse by calling themselves, look, my disease is, not alcohol. It's alcohol plus metabolic. So I think the metabolic thing is actually contributing. So I think, and even if you look at the other diseases like metabolic diseases like Wilsonian, lipodystrophies, they are actually metabolic diseases, but they are not included in MAFLD. So I think this is also, kind of creating a confusion, I feel. But the major confusion which I feel which is happening is why their suggestion, what they are saying is that the distinction between steatohepatitis and no steatohepatitis is not important, and they are trying to abandon the terminology of NASH. I think we have been following this terminology of NASH for almost 40 years. We have been taught that how important it is to distinguish between NASH versus no NASH. Their natural history is different, their prognosis is different, their treatment is different. And we know that this all comes from the liver biopsy, the distinction. But what they are suggesting now is that this all can be done non-invasively. This distinction is not required, and liver biopsy can be done only if there is an overlapping between different diseases. Otherwise, non-invasively, you can look at the activity and the stage of the disease. This, I feel, is really a confusing thing, and predominantly for, say, the non-hepatologists, and the major group I feel is the pathologists. Now, these pathologists have put in, 4 decades of their input. I think they, as I said, came out with this terminology of NASH. Now you're putting a sudden halt and saying that NASH is no longer a terminology and, this is kind of being abandoned. Now, whether you look at, the Brunt classification which came, or the NAFLD activity score, which is the NASH CRN score, or the SAF activity fibro score, all you are trying to distinguish between NASH versus no NASH. And we know fibrosis, no doubt, is the most important parameter for prognosticating patients with any chronic liver disease, including NAFLD. But NASH is the driver of fibrosis. I don't know whether Professor Saniyal is there. I have heard him saying in most of the meetings, saying that NASH actually tells you that at what speed are you driving. So which means that what speed is your disease going on. Whereas fibrosis is the end product. It tells you how much have you traveled in that journey, how much is the damage which is already done. So both are important. So fibrosis is nothing but the end result of NASH. And we know that how huge is the burden of non-alcoholic fatty liver disease. So this distinction between NAFL and NASH is very, very important, I feel. And I think by abandoning this terminology, I think this will be the biggest confusion. The other non-hepatologists are also getting confused. May these be, the basic scientists who are working on non-invasive biomarkers, the radiologists working on different kinds of elastography, shear wave, MR elastography, and, the MR PDFF. So many advances have been done, and suddenly now they will get confused that, what is this? The NASH is gone and the terminology is now becoming. And the gynecologists, I think they're working on PCOS. They understand the relationship between the polycystic ovarian disease, insulin resistance, fatty liver. Endocrinologists are working on SGLT2 inhibitors, GLP-1 agonists. So what I'm trying to say is that non-hepatologists are also getting confused. We need to have a wider consensus before we actually say that this terminology needs to be, taken. Now, the other point they are saying was about the patient organizations, and the public awareness is happening less because, this is a non-alcoholic fatty liver disease and there's a stigma attached to this. I personally feel calling somebody as non-alcoholic is actually destigmatizing. You are not causing any stigma. And in their expert, this thing document, they also mentioned about this, one of the patient association which had shown displeasure by this terminology of NAFLD. But, this is one organization. How about there are so many other organizations, societies, consortia, task forces, and if you look at the 25% of the world population having fatty liver disease, which would be maybe more than 1 billion. So where is the consensus amongst all those groups? So I think we need to have a wider consensus before we say that this patient organization or there's a problem with the public awareness. Finally, I think about the funding and the regulatory and the policymakers. I think even the no regulatory agency or the policymakers actually have told anybody to say that we are giving you less funds because this is a disease called non-alcoholic. There's an alcohol attached to it. So I think that's not the reason. And they are saying that because of this reason, since there's a stigma attached to it, alcohol attached to it, the attention is not coming in. I think there's a lot of progress has been made in the last 40 years. And I feel that if we have to do it all this, I think all the efforts which have happened in the last 40 years probably would go waste and we will have to start from scratch. Also, the issue of clinical trials. So in clinical trials, all the endpoints would say the resolution of NASH with or without, worsening of fibrosis. So now if you have a different endpoints in clinical trials and different parameters in clinical practice, I think this will further create, confusion. So I think, ladies and gentlemen, I think, I don't know whether I really made my point. I can actually go on and on, but then the time is limited. I was given only 15 minutes. So let me summarize what I said in last 15 minutes or so. So the nomenclature change, as I said, is good for science, good for medicine. Debates of these kind, I love it. Actually, these are very, very good. And the goal always is to, help our medical community, help our patients, help our society. But when we talk about changing name from NAFLD to MAFLD, my personal opinion is, as I said, we have the world leaders with us and we can have some more discussion. I feel for the time being, it is more of, eminence-based rather than evidence-based. And there is no compelling need for this change in nomenclature at present time. But yes, my thinking may also change as we have more data which may come in. I feel it is premature because the reasons for change are not solid. They are rather flimsy. And the change in nomenclature will not help the medical community. or our patients or our society. Rather, it will cause confusion, not only to the hepatologists, but all the non-hepatologists, patients and the patient organizations, regulatory agencies and policymakers. And as I said, it requires a wider consensus. I think, we have billions of population, we have millions of hepatologists, and I think the societies, the consortia, the task forces, and everybody has to sit together. Before I finish, I think when we wrote that commentary, I had sent that by WhatsApp to Professor Abbas, and I remember his reply came to me, and he said, "Rose called by any name will smell the same." So even whether you call it NAFLD or MAFLD, I think the disease would remain the same, and I absolutely agree with him. So rather than, changing the nomenclature and focusing our energy on changes nomenclature and look at the kind of publications which have come in the last 6 months, we should all get together to reduce the burden of fatty liver disease. Burden of NAFLD, global burden of NAFLD and your individual. We should all get together in better understanding of the disease and finding the treatment. There's not even a single drug which is still approved for this illness, except for now we have what drugs Saroglitas are in India. I think we should all get collected, have a wider consensus, and work more on that area rather than looking for the change, because the disease, even after the change, would remain the same. So thank you very much for your kind attention, and I'll be happy to take any questions. Let me stop sharing my screen now.
Thank you very much, Professor Ajay, for a very comprehensive and energetic talk. So we will be taking question answers and for discussion during the discussion session, and we've allocated it towards the end of the symposium. So this is a very burning topic, and I'm sure that lots of the questions will be coming about this topic. So let's move to the next talk. The next talk is about the biopsy-free non-alcoholic fatty liver disease, non-invasive versus histological modalities in the diagnosis and assessing the outcomes. And our speaker is Professor Laurent Castera. Professor Laurent Castera is the professor of hepatology, University of Paris, France, and he's also a visiting professor of University College London, Institute of Liver and Digestive Health, Royal Free Hospital. Professor Laurent Castera, we welcome you in our 14th annual meeting, and you can start your presentation.
Okay, good evening. Can you hear me?
Yes, we can hear you, and your slides are also visible.
Okay, and I can move to my slides? Yes, perfect. Okay, so first of all, I would like to thank the organizer for the kind invitation. So my task within the next 15 minutes will be to deal with non-invasive tests regarding diagnosis and prognosis. So diagnosis means NAFLD, NASH, advanced fibrosis, and there are two questions basically. Can non-invasive tests replace liver biopsy? Can non-invasive tests enrich patient selection for trial? And regarding prognosis, can NIT predict prognosis? So liver biopsy is impractical and has many limitations. First, because there's very high number of patients and a limited number of hepatologists, and even more limited of pathologists. It's invasive, it's prone to morbidity and mortality, also rare, to sampling variability, and also to observer viability. And this has been illustrated recently by this study that is in press in the Journal of Hepatology, with a large number of patients with per liver biopsy from a trial. And you can see that for the item, one of the endpoint in the trial, NASH resolution without worsening of fibrosis, the kappa between the different pathologies was very low, from 0.32 to 0.49. So as a result, there was a risk of misclassifying fibrosis subgroups and attenuating apparent treatment effect. So finally, of course, liver biopsy is also unrealistic and risky for all these reasons. So non-invasive tests are now ready for prime time. These are the Easel guidelines that have been published now 5 years ago, and that will be updated next year. And basically, we have serum biomarker with non-patented tests and patented tests. And I will focus mainly on the FIB4, the NAFLD fibrosis score, the ELF score, and we have elastography, for which the pioneer has been VCTE, transient elastography, better known as FibroScan, but we also have one shear wave elastography, such as RFI or 2D shear wave, and MR elastography. A critical issue when using non-invasive tests are availability, cost, and context of use. And of course, if you're going to screen patients in primary care, then of course, FIB4 and NFS will be more suited because they're widely available and cheap. On the other end, if you're in a tertiary referral center, you might use MR elastography, but that is costly and very limited availability. And finally, let me remind you that most non-invasive tests have been validated only in liver clinics so far. So first question, can we diagnose NAFLD using non-invasive tests? As for non-invasive score, this table summarizes the different scores that have been proposed, including fatty liver index or steato test, and some other. One of the issues with this test is they have been validated against different references, such as liver biopsy, ultrasound, or MRI. So the take-home message is that they do not add much to the information provided by clinical, laboratory, and imaging exam. What about now MRI, PDFF, and CAP? This slide summarizes the respective advantages and disadvantages of these two techniques. Regarding MRI, it's highly sensitive with very precise steatosis quantification, and actually it can be considered as a gold standard, even better probably than liver biopsy because you get the whole liver. Major disadvantages, it's time consuming, the availability is limited in many countries, and also the cost is an issue. As for CAP, it's a point of care technique, widely available as it comes with FibroScan, and you can also have concomitant liver stiffness measurement. Disadvantages are, I will show you very shortly, that quantification is suboptimal and quality criteria are not well defined. So regarding applicability, now the standard is using the Easel probe. As you can see, you can increase the applicability to more than 95% using the Easel probe. What about the performance? We have two large multi-center studies, one from the US. This is the one I'm currently showing. And you can see that for detecting steatosis, the OROC is not optimal, is 0.76. The sensitivity is 80%. But for a cutoff of 285, the PPV is above 90%. For quantification, you see that the OROCs are decreasing, meaning that it's not a good technique for quantification. Similar results were observed in the UK multi-center study, similar number of patients, and the OROCs were slightly higher, and the cutoff as well, but above 300, the PPV was 97%. What about comparison between CAP and MRI PDFF? We have 3 studies with head-to-head comparison that are summarized in this table. To make a long story short, CAP is outperformed by MRI PDFF, both for detecting and grading steatosis. So in summary, non-invasive score of steatosis are of little use in clinical practice. CAP is a promising point of care technique for rapid and standardized steatosis detection, but suboptimal for steatosis quantification. There are no consensual cutoff, but value above 275 have PPV above 90%. MRI PDFF is the most accurate technique for detecting and quantifying steatosis that outperforms CAP, but it's more suited for clinical trial given its limited applicability and cost. Therefore, ultrasound remains the first-line tool in clinical practice despite its well-known limitations. Now, what about diagnosing NASH? This slide summarizes the different marker scores that have been proposed for diagnosing NASH, and CK18 actually is the most validated and popular. However, none of these biomarkers are sensitive and specific enough to differentiate NASH from simple steatosis. What about transient elastography and MR elastography? Again, this table summarizes the different studies, and neither TE or MRE can confidently discriminate NASH from simple steatosis. So the message is that liver biopsy so far remains the reference for diagnosing NASH. Now, what about diagnosing advanced fibrosis? This is the most important issue in clinic because, as you know, patients with NAFLD and advanced fibrosis are the most at risk of complication and death. Liver-related mortality multiplied by more than 40 if you have advanced fibrosis, and overall mortality multiplied by 6. So, as you can see, for the serum marker, we have large meta-analysis for NAFLD fibrosis score and for FIB4, as well as more recently for ELF, and the OROX range from 0.78 to 0.83. So they are the most validated markers, as you can see, as compared to all the others. What about the advantages and disadvantages of patented versus non-patented tests? And FIB4 and NFS, they are simple and free. They can be performed at bedside, widely available, acceptable accuracy around 0.8, and high negative predictive value above 90% for ruling out advanced fibrosis. Main disadvantages is modest positive predictive value below 70%, undetermined results in around 30% of cases, and influence of age also is still a matter of debate. As for ELF, there is slightly higher performance, as I've shown you, and much higher specificity, but less external validation, limited availability, and cost. And actually, if you look in this study from the STELLA program, head-to-head comparison between these three markers, you can see that although ELF performs slightly higher than NAFLD fibrosis score and FIB4, widespread application is limited by cost and availability. Now, what about elastography? This table summarized the level of evidence in meta-analysis. And as you can see, the higher level of evidence is for transient elastography, and OROX are very high, around 0.90 or even higher with MR elastography. If you compare the different technique available, as I already mentioned, the level of evidence is the highest for transient elastography. It also comes with CAP. As I mentioned, the failure rate with the Easel probe is now low. It's a point-of-care technique and widely available as compared to the other techniques. So it's clearly the technique of choice in clinical practice. Now, what about the cutoff you're going to use? If you're using a cutoff of 8 kilopascal, the negative predictive value is high, satisfactory above 90%. In between, then, if you're above 10 kilopascal, you can see that the PPV is suboptimal, 46 to 64%. Even if you increase, let's say, to 14 kilopascal, for instance, the PPV is still suboptimal with 25% of false positive patients. Should we adapt cutoff according to the probe, M and Easel probe? And we have this interesting study from Hong Kong, 500 biopsy-proven NAFLD that underwent transient elastography with both M and Easel probe. And you can see there was no difference in terms of accuracy between M probe and Easel probe. And the take-home message is that same cutoff can be used with M probe, provided it's used for patients with BMI below 30, and Easel probe in patients with BMI above 30. So to summarize, when you compare head-to-head elastography, patented test and non-patented test, usually the advantage is to elastography with higher ROX and that perform better than patented tests that perform better than non-patented tests. So just to summarize, FIB4, NAFLD fibrosis score, ELF, transient elastography, and MR elastography are the most accurate and validated non-invasive tests for assessing advanced fibrosis. FIB4 and NFS are widely available and easy to use with high negative predictive value for ruling out advanced fibrosis, thus more suited for primary care. ELF and transient elastography using the Easel probe, they are less available and more costly, with higher positive predictive value for ruling out F3, F4, and more suited for secondary care. Sequential combination of FIB4 and NFS and VCTA confers additional diagnosis accuracy for ruling out and in advanced fibrosis. This I'm going to show very shortly. And finally, MR is more suited for trial given its cost and limited availability. So how can we use this test in clinical practice? This is the algorithm that we have proposed last year with Rohit Lumba. And most of patients with suspected NAFLD are seen either in the diabetes clinic or mostly by general practitioner in primary care. And of course, you always have to rule out alcohol and viral hepatitis. And after, you will screen them for fibrosis. And the best way, of course, as serum marker, FIB4 or NFS, but FIB4 is probably easier to do in primary care because NFS requires albumin and fasting glucose. So if you're below 1.3, you're at low risk, and this patient do not need to be referred to an hepatologist. Above 1.3, I think we choose a single cutoff instead of a dual cutoff to make it very simple for GP. Otherwise, we think it will never work. Patients are intermediate to high risk, and they should be referred to the hepatologist. Then you need to be prepared to a little bit of over-referral with a strategy. And then, of course, you come up with elastography and transient elastography to rule in advanced fibrosis. As I've shown, if you're below 8 kilopascal, the patients are at low risk of having advanced fibrosis. Obtain lifestyle modification and exercise, and of course, you can repeat evaluation every year. When you're above 8 kilopascal, then you might discuss on a case-to-case basis a liver biopsy. And of course, this is guided also by the availability of therapeutic trial, for instance. In case of failure, of course, you can consider alternative methods as I've shown. Now, before concluding, I would like to touch briefly on the enrichment in trials. Several scores have been published this year, and I just want to touch upon the FAST score, that is CAP, liver stiffness, and IST. And it's a score that is available for free with an app, and the objective is to capture patients with NASH defined by a NASH score above or equal to 4 and significant fibrosis above or equal to 2. The score go from 0 to 1. Our rocks are pretty good. And these are the result in the validation cohort, and below 0.35, as you can see, the negative predictive value is very high, above 90%. Above 0.67, the positive predictive value is not as good, less than 70%, and around 30% of patients fall into the indeterminate category. As a result, 60% of these patients were correctly classified and could have avoided the liver biopsy. We need, of course, more validation and external validation. What about now prognosis? I will deal briefly with complication and mortality and trying to answer whether NIT can predict prognosis. So regarding FIB4 and NFS, we have this large study from Sweden. You can see retrospective analysis, very long follow-up, 20 years. And you can see that both NFS and FIB4 were able to predict complication and overall mortality, even though the ROCs are, let's say, suboptimal. Recent data also from the US in NAFLD patients with paired liver biopsy, it's a retrospective analysis again, and fibrosis progression could be detected using NFS and FIB4, and also an increase in NFS and FIB4 over time was associated with fibrosis progression. Now regarding ELF, this is again the STELLA program where you can see that with different cutoff, it was possible to predict progression to cirrhosis and liver-related event in this population. What about liver stiffness? We have this study from France showing that liver stiffness has been shown in viral hepatitis, is able to predict complication and overall mortality in NAFLD as well. And very recently, this is a paper that is in press in clinical gastroenterology and hepatology. And again, the changes in liver stiffness were associated with mortality, liver-related mortality, and overall mortality. And for instance, if you have an increase in liver stiffness above 20%, you could see that the liver-related mortality was higher, 7.7%, with a median follow-up of 35 months, as compared to patients with an improvement in liver stiffness. So these are my take-home messages. Ultrasound remains the first-line tool for detecting NAFLD. Liver biopsy remains the reference for diagnosing NASH. FIB4, NFS, ELF, transient elastography, and MRE are the most accurate and validated non-invasive tests for diagnosing advanced fibrosis. In clinical practice, as I've shown, the optimal strategy is a sequential use of FIB4 or NFS to rule out advanced fibrosis, then transient elastography using the Easel probe to rule in F3, F4 in secondary care. Non-invasive tests may be useful to enrich patient selection in clinical trial. And finally, they also may be helpful to stratify the risk of liver-related outcome in NAFLD. Thank you very much for your attention.
Thank you very much, Professor Castera. So moving from here, after non-invasive tests well elaborated by Professor Castera and the limitation of liver biopsy, and again the decreased acceptability from the patient's end for this procedure, which is associated with risk. Our next talk is about evidence-based approach to the management of NASH without histological assessment, and the speaker is no one else but Professor Arun Saniyal. Professor Arun Saniyal is the Professor of Medicine, Physiology and Molecular Pathology at Virginia Commonwealth University School of Medicine in Richmond, Virginia. He is the Education Co-Director, Kenneth and Dean with Center for Clinical and Translational Research. He's a very rich biography and author of a number of great publications, and he will be talking about the evidence-based approach which what a clinician can do in the daily practice. So Professor Arun J. Saniyal, we welcome you here.
Here are my conflicts of interest. So for everyone attending the Paris NASH meeting, I think I do not need to state that there is an urgent unmet need for effective therapeutics in NASH, and that the number of incident cases of cirrhosis, decompensated cirrhosis, and liver-related deaths is increasing and is projected to continue to increase unless we figure out a way to stop it. This, of course, has formed the basis for our current regulatory path, where for pre-cirrhotic stages in subpart H, we have to demonstrate resolution of steatohepatitis without worsening of fibrosis or improvement in fibrosis without worsening of activity, followed by post-subpart H, where we demonstrate progression to cirrhosis and reduced clinical outcomes. Whereas in cirrhosis, we have to show improvement in fibrosis stage, reduction in MELD progression, and then eventually clinical outcomes. So this is based really on histology. And even our current state-of-the-art NASH management, based on current practice guidelines, is also anchored in histology. I show you on this slide different steps in the course of the patient's life and how these are to be approached based on the most recent ASLD guidelines, where for populations at risk, we have no guidance. Diagnosis if fatty liver disease is present, we recommend liver biopsies, particularly to identify steatohepatitis, determine prognosis, again with biopsy, and use that to decide who actually needs to be treated with a pharmaceutical agent. And then we have to pick the best possible treatment. And once we start treatment, we have to define the response to treatment, for which, again, there is no specific guidance. But the implication is that we will use histology to make this decision-making process. Now, here's the problem with this issue. First, that neither drug development nor clinical care paradigms are optimal. And the case I will try to make is that the emperor is definitely not well dressed. Why is that? Well, first, liver biopsies are not a viable approach for large-scale use in routine clinical practice for everyday decision-making. It is invasive, painful, carries risk, including the risk of mortality. There's sampling variability, observer variability, and there is a limited workforce capacity to actually read all of these biopsies. I just want to point out that the risk of a severe bleed after a liver biopsy is 1 in 1,000, and the mortality rate is 1 in 10,000. Assuming that there are 100 million people, a third of the US adult population, have fatty liver disease, just using simple numbers here, this would translate into 100,000 significant clinical bleeds and 10,000 deaths, which is clearly unacceptable. Furthermore, we know that histological assessment is not precise. An ideal assessment tool should be specific, measurable, attainable, relevant, and time-bound. Yet we see that the kappas for assessment, as shown in this recent paper, is as low as 0.299 in some cases, even with very high-quality pathologists reviewing the biopsies. The public health consequences of this is that very few patients with NASH have been identified, and their disease is today progressing to cirrhosis as we speak. Over 50% of patients with cirrhosis present with a complication of cirrhosis. What that means is they had cirrhosis, they had chronic liver disease, they developed cirrhosis, nobody identified them because our current approach, which is anchored on histology, means nobody's getting this test done. And this, of course, has an impact on drug development because of the recruitment challenges, challenges in meeting entry criteria, and then at the end of the study, to be unclear if all the patients in the study actually met the entry criteria and the potential for exposure of patients to the risks of a diagnostic test, including mortality. So all of these set the stage for why we need a non-invasive way of assessing patients that is applicable in everyday practice and also for drug development. So let's go back to the ASLD guideline and the different points in time where we can intervene, starting with the population at risk for which there is currently no guidance. So here's the data. We know that there are several populations where the prevalence of the PNPLA3 mutation, for example, is extremely high, up to 48% in Hispanic children. And the likelihood of people having the GG allele having more than 10 to 15% steatosis is very, very high. There's also now data that the steatosis and fibrosis are indeed linked. And so, at least in this population, you could make the argument that in those who you do know have genetic polymorphisms that put them at risk, if they are obese, they need to be targeted for more aggressive therapies for the underlying obesity and insulin resistance. Because in the absence of that, the risk of having significant liver disease is relatively low. Now, moving on to the more common problem of the patient who arrives with suspected fatty liver disease, the current guidance is that you should confirm it with a biopsy, particularly to look for steatohepatitis and advanced fibrosis. This, of course, tells us about prognosis. So let's really take a critical look at what histology actually tells us and how we can get around it. So the basic steps in NASH management are really three. Is fatty liver disease present? Does it require intervention? And if so, what intervention? So let's walk our way through this. So what histology does is it tells us if you have fatty liver disease, if there are competing etiologies that were not otherwise detected, what is the prognosis, which is linked to fibrosis stage. It does not tell us which target is driving the disease forward in a given patient. And so it does not give us insight into what drug would be best for an individual patient. And of course, we use this to assess if patients are responding to treatment. So looking at all of the information that histology does provide us, let's see if we can get the same information without doing a biopsy. We know that the pretest probability of having fatty liver disease can be as high as 75% if you have multiple features of the metabolic syndrome, as shown over here. And furthermore, not only is the pretest probability very high, this is a different study from Ken Cusi, but he actually did biopsies in these patients and showed that the prevalence of NASH in this population is 56% in a population of patients with type 2 diabetes. So if you have multiple risk factors for metabolic syndrome and you're obese, you have a very high pretest probability in the 75–80% range of having fatty liver disease, and a 50 to 60% probability actually having steatohepatitis. So we have a pretty good idea how to answer the first question. We don't even need a whole lot of tests, because if the test tells us otherwise, it's likely to be wrong. That's just Bayesian theory. Now we also know there are additional non-invasive tools. So the PDFF has emerged as the gold standard for non-invasive assessment and quantification of steatosis, as shown on the left. And the CAP score from the FibroScan also identifies the presence of excess fat in the liver with a positive predictive value of 0.96, which is pretty darn good. So we not only have a way to understand the pretest probability of having fatty liver disease and NASH, but we also have very good non-invasive tools to identify the first question, whether you have fatty liver disease. Ability to distinguish alcohol from NASH is a very, very difficult issue. Now, people who are expert pathologists, and these are slides from Professor Brunt, she tells me that you see florid Mallory-Denk bodies, you see these ductular lesions, cholestasis, and this fibro-obliterative venulitis around the central vein. When you see these, it's much more likely that you're dealing with alcohol-induced steatohepatitis. But there are a lot of patients, most of these patients, if your liver looks this yellow, almost guaranteed your patient is fluorescing in the dark. You do not need too much to figure out this is alcoholic hepatitis and that this is not really NASH. But for the patient in your outpatient clinic who is obese, diabetic, and has more than a few drinks, it becomes very, very complicated. And there are no good histological tools that clearly and with great sensitivity and specificity make this distinction. So we have to rely on clinical tools. We do know that in the general population, there's a lot of alcohol consumption, particularly in the era of COVID. So this is a study where adults in the US, 10.5 to 22.5 in various states, and up to 7.2 to 25.3 in this area where there was people who were in these metropolitan areas reported binge drinking within the last 30 days. That's 1 out of 4. Also, within people with obesity, you can see there's a huge prevalence in these different areas. So almost certainly there's a large overlap population that has multiple things going on. And you have to rely on good history taking and clinical tools. And the audit 3 questions is a good additional tool to help us get to that point. The bigger question is, does the fatty liver disease require intervention? And that is based on the presence of steatohepatitis and the degree of fibrosis. Now, there's lots of data that stage 2 fibrosis onwards is associated with increasing mortality, and all-cause mortality increases even a little bit earlier, and then certainly for liver-related mortality. And this is the basis for how we pick patients for pharmaceutical intervention. There are multiple tools that have been developed that can identify this at-risk NASH population, people with NASH and stage 2 or higher fibrosis. And one common one is the FAST score, which includes the CAP from FibroScan, liver stiffness from FibroScan, and the AST. And this is a paper that has been published now, and you can see that there are multiple cohorts in which it has been validated, providing very good area under the curve. We have independently validated this in the NASH CRN as well, and the data actually look just as good as that reported by EchoSense. The NIS4 is another upcoming biomarker tool which combines miR34A, alpha-2 macroglobulin, YKL40, and hemoglobin A1C. It has been trained in patients in the GOLDEN trial, and has been validated in patients who were being evaluated for the Resolve-IT trial. And as you can see, you get very good aurochs in the training set, validation set, and then finally in an optimization set. And this work has also now been fully published. So there are multiple tools that are emerging that can identify this at-risk population with relatively great accuracy. So some years ago, we were asked by Nature Gastro and Hepatology to provide some common sense clinical guidance that clinicians could use. And we came up with some criteria, putting patients into a green bucket based on a safe bucket with low probability of outcomes, a reddish bucket with high probability of outcomes, and an intermediate orange bucket. And these are, again, based on markers of fibrosis such as FIB4, AST to ALT ratio, platelet counts, and then liver stiffness, and so on and so forth. But this was never really validated. This was based on sort of our clinical gestalt and the available literature at the time, linking some of these to fibrosis. So we have recently modified and quantitatively operationalized these risk strata as shown in this slide. And we divide this into patients with class A, class B, and class C. So this is sort of our new version of the NASH class that can be actually applied in your clinics, because other than a fibroscan, and even without a fibroscan, just with a hepatic panel and a CBC, you should be able to apply this in your routine clinical practice. And these slides will be available afterwards online. And this work will be presented at ASLD in more detail as well. And what we see is in a prospective cohort of about 2,500 patients followed for a median duration of 3 years in the target NASH target study, we report the rate per 100 person years for class A, B, C, and then for those who are upstaged using the AST to ALT ratio or isolated thrombocytopenia criteria. And you can see there are pretty good numbers in each of these. Now let's start over here with mortality. It goes from 0.07 per 100 person years to 0.42, which is a 4-fold increase, and then an almost 10-fold increase to 3.08 in class C per 100 person years. Liver events go from 0.21 to 1.32 to 9.33, while MACE goes from 0.8 to 1.6 to 2.54, and HCC goes from 0 to 0.07 to 1.08. So this again shows that without a biopsy, I can predict the likelihood of death, liver events, ascites, encephalopathy and bleeding, MACE, and hepatocellular carcinoma, with probably just as much accuracy in predictive power as a biopsy. So this, I think, should give evidence that people can use to start risk stratification in their clinics and then use that as a rational way to approach and manage their patients. So then it brings us to what interventions. Once you decide somebody actually is at high risk and you're going to treat, what intervention? There are no drug approved for NASH at this point in time, but there's evidence that several things can help. Bariatrics is a viable option for some patients. We know there's an improvement in vascular events following bariatric surgery compared to medical therapy, summarized in this meta-analysis of several thousand patients. In a separate meta-analysis where histology from the liver was obtained, steatosis resolution 66%, improvement in all the other parameters, fibrosis improvement in 40%. But of course, there's a small subset of people whose fibrosis worsened. How much of this is due to sampling variability, we don't know. And of course, the quality of this data was not considered to be very high. But there's no question that there's just cumulative evidence that in selected people who have an appropriate indication for bariatric surgery, if they also have NASH, that this is a reasonable option. There's a retrospective study showing that vitamin E in patients with NASH in stage 3 and 4 fibrosis can actually reduce mortality. This is data showing transplant-free survival and, of course, hepatic decompensation. And I think this is really potentially very important because we already know from the PIVENS trial that you can improve steatohepatitis in the short term. Now, this data is retrospective and needs to be confirmed in more advanced trials. GLP-1s are coming on strong. These are data from liraglutide. These are the cardiovascular benefit data and the liver benefit data from Armstrong's study. And the semaglutide data, which has been reported at high level right now, the manuscript is pending, also further suggests that you can improve NASH with a small improvement in fibrosis, but whether that translates into reduced progression to cirrhosis, time will tell. But those treatments, because of the background diabetes, are rapidly going to become frontline treatments. In the future, we will use molecular targeting and this is a proof of concept paper we published last couple of years ago now almost, showing that even within people whose biopsy looks the same, molecularly at a transcriptome level, they're in distinct clusters of patients with genes related to immune regulation, cell proliferation, and fibrosis that are particularly turned on. How these translate into progression and therapeutics is something that's being actively looked at. But eventually, we should be able to get to this. And at this meeting, there's also a talk deriving iPSC cells from circulation of patients with NASH and looking at the gene expression profile in them and relating it to the liver biopsy of patients with NASH, and shows that there's considerable concordance. So going forward, that may be a very interesting tool to actually identify what's happening in the liver and develop precision medicine for this population. Then once you start treatment, how do you monitor these patients? So we're now coming back down to the lower part of this slide over here. And once again, the ASLD practice guideline does not give us specific guidance on this, although they imply in the text that the fibrosis improvement is best captured by histology, which is the reference standard, and that's all correct. However, the problem with the biopsy-based approach remains what we talked about before, and I'm not going to reiterate that. So how can we look beyond biopsy to get the same information? So these are data we published last year from the Symposium trials that were done by Gilead. And what we see here is not only is the fibrosis stage, but lack of improvement in fibrosis over time, hepatic collagen content. But look here, the ELF score, which is the extended liver fibrosis score, at baseline and change from baseline, both were associated with higher hazard ratio for improvement in, for progression to clinical outcomes. Now, at this ASLD in a few weeks, I will further show that regression of cirrhosis in the STELLAR trials actually correlated with reduced clinical outcomes, and these could be captured by non-invasive tools. So we have already data going in both directions. Furthermore, we know that NITs can detect progression to more advanced fibrosis, and these are data from the NASH Clinical Research Network that were published, again, I think last year. And as you can see, that you can look at prediction of progression to fibrosis stage, as well as progression to advanced fibrosis from early stages. FIB4 also has been shown in the Flint trial to correlate with decrease in fibrosis. Similar data have been obtained in Regenerate. And over here, you can see the aurochs. They're modest. There's probably room for improvement, but it provides proof of concept that these non-invasive tools have the possibility of capturing changes in fibrosis stage over time. These are data from the Regenerate trial that was shown last year at ASLD, where you see that several markers actually improve in patients. And these are data for liver stiffness, and you can see improvement in the active arms in those whose fibrosis improved, relatively stable in those whose fibrosis did not change, and modest worsening or slight or about the same in those whose fibrosis actually worsened. So let's summarize what we just talked about. Consider high-intensity obesity treatment for at-risk populations. In high pretest probability population, CAP and liver stiffness can actually, and FIB4 can actually give you a pretty good handle on whether there is steatohepatitis and significant fibrosis, whether the patient has at-risk NASH. Management options include weight loss, GLP-1, SGLT2s, particularly in type 2 diabetic patients for whom there is an indication, Statins for cardiovascular risk management as indicated. None of these require a biopsy, by the way. And potentially vitamin E as a second-line treatment. Long-term monitoring, the possibility of monitoring this with liver stiffness and FIB4 has already been shown. It could obviously require some further refinement, but we can assess this for progression to advanced fibrosis, for which it's actually pretty good. HCC screening in advanced fibrosis is the decision-making that this would lead to. And many NITs remain currently in development. Finally, a couple of words about drug development. So we said, what I've shown you is that it is actually now possible, for the most part, to manage patients in your regular day-to-day clinic without relying on biopsies, and yet having an evidence base to support the things that you do. An alternate paradigm for drug development is to recognize detailed baseline characterization may not be essential in trials when the mechanism of action targets the root cause. You could define a large population non-invasively and follow them to a composite endpoint of all-cause mortality, liver mortality, progression to cirrhosis, CKD, and MACE. All of these can potentially be assessed non-invasively. And progression to cirrhosis, I think this is a big unmet need in the area of biomarker science. Once we are there, then it will be up to companies to actually bite the bullet and avoid the problem of all these screen fails that they're currently struggling with, and be able to enroll very large trials much faster, very similar to diabetes trials and cardiovascular trials, and follow them to outcomes. An alternate paradigm is to actually look at individuals who have more advanced disease. This is a more liver-targeted paradigm, focusing on people with fat and advanced fibrosis, and again, treating them to show that the treatment actually reduces outcomes, which is really where the rubber meets the road. Histology is a surrogate along the way. What you're trying to understand is whether eventually you will reduce the likelihood of somebody dying from their liver disease. So the challenges, of course, are what to do with heterogeneous response, and it does take time to develop outcomes. But as we develop more tools to parse this population in a more refined manner, that may also become feasible. So with that, I'm going to stop, and I hope I have provided for you today an overview of where the field is going in terms of being able to identify the population, determine prognosis, develop therapies, and follow the patients using simple tools that are routinely available, and also to use these to change our drug development paradigms, which are somewhat antiquated in 2020. Thank you for your attention.
Thank you very much, Professor Saniyal. And let's move forward from the diagnosis and assessment towards a different paradigm, which is gut-liver axis and the microbiota in non-alcoholic fatty liver disease, a link to emerging therapies. So here we are honored to have Professor Jasmohan Bajaj, who doesn't require any introduction, and a well-renowned, world-class expert with a special interest in microbiota in context to fatty liver disease. So Professor Jasmohan Bajaj, we welcome you over here, and please grace the screen with your presentation.
I would like to thank the organizers for inviting me for this talk. There's the outline: gut-liver axis in NAFLD, changes before and after cirrhosis, longitudinal changes, modulation using therapies such as prebiotics, probiotics, diet, gastric bypass, fecal microbiota transplant, and FGF agonists. So this is the incredibly complex altered gut-liver axis. You have the microbiome, the epithelial barrier, the gut vascular barrier, and the portal venous circulation, in which the microbiota interact with the food, xenobiotics, the multiple aspects of the gut barrier, as well as send their products, as well as translocate to the liver via the portal vein and throughout in using their products. And this can incite a whole lot of reactions in the hepatic stellate cell and actually can worsen liver fibrosis. So microbiota structure and function is impacted by many things, including liver disease stage, alcohol, antibiotics, comorbid conditions, diet, organ failures, and host genetics. So this is very important for us to realize that microbiota is just one part of many things that may go wrong or right in a patient. So what happens to the stool microbiota composition in patients with cirrhosis, pre-cirrhotic stage of NAFLD? In these studies, it is clear that the Enterobacteriaceae is higher in NASH, and especially Escherichia is higher in NASH. And you look at the bacteroidetes to total bacteria ratio, it is the lowest in NASH, which tells us that these patients, even before cirrhosis, are much worse off compared to healthy controls. And again, in this study as well, certain autochthonous or good bacteria are lower in NAFLD compared to controls, even before the development of cirrhosis. With cirrhosis and advancing fibrosis, things get even worse. You can have NASH with fibrosis on the left-hand side with F2, and if you look at the red, it goes from 0 to F2. And even in cirrhosis, this is NASH cirrhosis versus non-NASH, and alcoholic cirrhosis versus non-alcoholic. There's a different stamp of the microbiota in alcoholic cirrhosis versus non-alcoholic cirrhosis. And what is more intriguing is of late, there have been more studies, firstly in pediatrics and then in adult populations, that certain bacteria, especially belonging to Klebsiella, can actually produce alcohol that can cause an endogenous fatty liver without any drinking of the alcohol, that bridges the gap between the alcohol and the non-alcoholic fatty liver disease. Can we predict the presence of NAFLD in pilot studies? It is clear from small studies that the AUC of 0.937, that the gut microbiota derived signature with high E. coli, high proteobacteria is in patients, can detect patients with NAFLD. And again, blood microbiota diversity, in which people who have fibrosis have high copies of serum, but low diversity. What it means is small groups of bacteria are present in larger quantities in people who have fibrosis and NAFLD compared to people who don't. However, we need more studies of this and multi-center studies to increase the uptake of this methodology, but it is actually specific. It is actually interesting that this is the case. So fecal bile acids in NAFLD compared to controls are also different. And why are these important? Because these are things that are modified and modulated by the gut microbiota. And so not only do we worry about the structure of the microbiota, we are worrying about also the composition. And this happens in cirrhosis as well. However, so this range may actually not be specific for NAFLD, but it rather might be for cirrhosis. What about longitudinal changes in microbiota and NASH? We talked about static changes already. In this study, they correlated the intrahepatic triglyceride content with the fecal bacteria abundance over 6 months. And when the NASH resolved, there was lower intrahepatic triglycerides and higher bacteroidetes and lower firmicutes, which again tells us that the gut-liver axis goes hand in hand and the microbiota are important. Now, it's difficult to know what's the chicken or the egg, but these longitudinal studies help us understand that. In this very nice study, which is now almost 9 years old, they actually fed a choline-deficient diet, which you know is one of the models of NASH in animals. In humans as well, it actually induced NAFLD in healthy people. And what they found is gamma proteobacteria and erysiperotrachea abundance, particularly when combined with host genotype, predicts who develops choline deficiency-induced fatty liver. So this is another important concept of why people might be susceptible to NAFLD, why some people might be versus others. So what are the microbial therapies in NAFLD, which is what this is building up to? Because we know even with and without cirrhosis, there are changes in the structure and function of the microbiome. And also these can be modulated by reduction or increase in NAFLD. So what is the non-cirrhosis NASH therapy outlines for the FDA, as has already been shown and will be talked about in the rest of the session? In the early phase 2, you need histology change with proof of concept. In late phase 2, you definitely need histological change with biomarkers, at least 12 to 18 months. And what do you need for an ideal probiotic or microbiota study? You need defined strains with minimal variations in CFU or colony-forming units per dose or batches. Engraftment, localized, and systemic actions should be known. We want to know if there's changes in the microbiota composition and function. We want to know if the probiotics or the other organisms can be recovered from the stool, and they should ideally be a clinically relevant endpoint. In this study of probiotics and NASH, there's only one study that actually goes for 6 months. And therefore, the problem is the longer the duration of the study, the lesser is the sample size. And there are few studies with histological endpoints. Same with prebiotics and same with symbiotics. Some studies are for a longer duration, but currently none of the studies here are important for us, are large enough, long enough for us to actually make probiotics a viable alternative at this point. What about fecal microbiota transplant? This is very radical because you want to change the microbiota completely by using someone else's microbiota in the patient. So on the left-hand side, these are patients with metabolic syndrome. This is a smaller study done by Vries et al. in gastroenterology. And you can see they have divided the patients who got an allogenic or autologous fecal microbiota transplant. And what's very interesting, in these patients with metabolic syndrome, not necessarily NAFLD, there was an improvement in the short-term insulin sensitivity after fecal microbiota transplant in allogenic, which means got it from someone else. However, when they tried to do it at a longer time period, this did not work as well. And this again did not work in another study done from Canada, allogenic and autologous transplant. There was a minor changes in the HOMA-IR score and a minor reduction in intestinal permeability, but it became very difficult, even after 24 weeks, to make any meaningful impact that would satisfy either the FDA or any other regulatory agency that at least at this point, fecal microbiota transplant is something that would be a viable alternative. And what is going to happen in the future? These are studies that are actually in progress right now with FMT, amongst other diseases. But it tells you that you need to have a lot more of these transplants done in a patient, because ultimately you're changing just one part of the gut-liver axis. The liver does need to be changed as well. And more importantly, fecal microbiota transplant is not without its risks. You want to weigh the risk and benefit. And there might be some alternatives available, but this is not currently a situation where you want to treat it like C. difficile, where one is done. You may have to do multiple transplants in these patients in conjunction with diet and exercise. What about other methods to actually modify the microbiome? In this nice study done by Dr. Lumba Ling and Dr. Saniyal, who spoke before amongst many other investigators, aldifermin, which is an FGF19 analog response, was associated with Veillonella abundance in bile acid changes. In this study, cohort 1, 2, and 3, you can see the prior study that was published showed that there was benefit, and they found that with the higher dose, the Veillonella abundance tended to increase, and the positive patients who were positive with Veillonella at week 12 was higher in the people with the higher doses of aldifermin. And moreover, this was linked with the bile acids in these patients. So it tells you that not only does microbiota get affected, microbiota analysis may actually predict who responds to specific drugs, and especially if it's a bile acid analog like an FGF19 analog like aldifermin, then the bile acids really is a nice proof of concept here that these are the patients who we might select to move forward. So where do we stand right now as far as microbiota are concerned with NASH? And you can see this is the history of NASH. You have fatty liver, which majority remains stable, but some develop NASH, going on to cirrhosis, liver failure, hepatoma, and death. This is where most of the studies are. Very small duration, very small patients who develop this. So the question is, how should we proceed? For an ideal probiotics or microbiota study, you want to prevent cirrhosis, because fibrosis is when people actually end up getting negative consequences. And you don't only have to have one, but multiple and sustained attacks on the microbiota to make it so that the patients get better. Right now, none of these studies are long enough or large enough to do this. So what is the summary of treatments of microbiota? Currently, is not very convincing. Prebiotics, probiotics, symbiotics, and antibiotics. Fecal microbiota transplant is short-term not successful. Obeticholic acid has been studied, but there's a concern for LDLC. Aldifermin, we just talked about, associated with Veillonella increase and changes in bile acids. And this is a nice summary summary that came out recently with personalized nutrition, targeting gut gut dysbiosis, using many of the techniques we just talked about, gut barrier integrity using TLR inhibition, and microbial metabolites such as engineered microbiomes, postbiotics, etc., and modulation of bile acid physiology are some things that are actually in the pipeline, but many of these need longer and larger studies. So in summary, NASH is a multifaceted disorder which is associated with an altered gut-liver axis. Bile acid perturbations and microbial composition changes worsen over the course of fibrosis severity, with more extreme changes towards cirrhosis. Treatments for NASH are increasingly focused on the gut-liver axis with modulation of bile acids. At this time, there's inconclusive evidence that using pre-pro symbiotics, or rather any other predominantly microbial condition, including FMT, can improve NASH from a regulatory standpoint. There is enough proof of concept right now. Gut microbiota changes in NASH will likely be part and parcel of an overall strategy to treat the metabolic syndrome. These are my acknowledgements, and thank you for your time.
Thank you very much, Professor Jasmohan Bajaj. It was a very comprehensive and interesting talk. So let's move to the next talk, which is about the treatment. So as we all know that the treatment about non-alcoholic fatty liver disease is a very, very, very challenging area. So our next speaker is Professor Zobair-M. Professor Zobair-M is well known, we all know, and the very well renowned faculty with expertise in the field of non-alcoholic fatty liver disease. He is the chairman, Department of Medicine, Innova Fairfax Medical Campus. He is also Professor of Medicine, Virginia Commonwealth University, Innova Campus, and affiliated Professor of Biomedical Sciences, George Mason University. A huge profile in terms of research and publication, and we welcome you, Professor Zobair-M, for gracing the screen, and he'll be talking about current and future therapeutic landscapes for non-alcoholic fatty liver disease. Professor Zobair-M.
Now, before we get started about what treatment regimens to use, what treatments are available currently or in the future, let's consider what is the burden of non-alcoholic hepatitis as a disease, and what outcomes are important and will be effective treatment. And when you look at the burden, the comprehensive burden of non-alcoholic fatty liver disease, you're talking about clinical burden, you're talking about PRO burden, like what's actually related to patient experience, functional burden, and of course economic burden related to resource utilization. Since you can't actually always measure clinical outcomes such as mortality outcome, which is a hard outcome, then we will also look in clinical trials for surrogates, and the surrogate for NASH, this surrogate that's histologically stage of fibrosis, as well as resolution of steatohepatitis, or that's another surrogate, and of course regression of cirrhosis would be important. From PRO standpoint, of course, health-related quality of life is very important, surrogate of patient experience. And of course, you have surrogates for functional assessment, activity of daily living, or ADLs would be important. And finally, for research utilization, burden of illness, cost of illness, budgetary sort of costs are all important, needs to be considered. So in the context of treatment, we need to consider all these aspects to reduce the burden of non-alcoholic steatohepatitis, not only for the patient, but also for the society. Now, let me spend a minute or two to talk about what is the evidence that you've already heard today, some of this data about NASH. So we know that prevalence of NAFLD from this meta-analysis globally is about 24%. Highest prevalence being in Middle East and South America. North America and Europe, about 24%. In Asia, about 27% data. More recent data suggests that maybe over 30%. When you look at patients with type 2 diabetes, the prevalence of NAFLD is 55% or more. In kids and children, the prevalence of NAFLD is about 7.6%. And again, the highest prevalence of NAFLD in children is from South America, about 25%. Now, the progressive form of NAFLD, which is called non-alcoholic steatohepatitis or NASH, the prevalence is about 1.5 to 6.5%. And when you look at those patients that have type 2 diabetes, about a third of them will have underlying non-alcoholic steatohepatitis. Let's put this into some numbers in this context. And this data from the United States with the U.S. population of over 325 million people. And as you can see, the number of patients that could potentially have NAFLD is enormous. 79 million people could have NAFLD. And we look at NASH and then the number of patients with NASH cirrhosis, you're talking about 680,000 individuals that can have significant fibrosis related to non-alcoholic steatohepatitis. And this is not unique to the United States. This burden is actually being modeled for Asia, for Europe, and for the rest of the world, and some of the data is actually being generated. In the United States, when you look over time, this is from enhanced data, you see that actually from the 4 most common causes of liver disease, hepatitis B, hepatitis C, alcoholic liver disease, and non-alcoholic fatty liver disease, that hepatitis C is declining in green. Alcoholic liver disease and hepatitis B are stable. Non-alcoholic fatty liver disease is going up. And in fact, when you look at mortality, both in men and women, this is from, again, the United States data. When you look at actually compared the mortality from health statistics to hepatitis C, you see that the black line, that hepatitis C mortality is decreasing. On the other hand, NAFLD is actually increasing. It's already the second indication for liver transplantation in the United States is related to NASH. And in fact, in women is the top indication for liver transplantation. It's among the top 3 causes of liver cancer in the United States. And when you look at it globally related to mortality, related to 4 different liver diseases, hepatitis B, C, alcoholic liver disease, non-alcoholic fatty liver disease, you see related to liver cancer mortality or cirrhosis mortality, that especially in cirrhosis mortality, hepatitis B, if you look at different regions of the world, has these green boxes, meaning that there's actually an improvement in mortality related to cirrhosis secondary to hepatitis B. On the other hand, when you look at NAFLD, both from liver cancer and cirrhosis, there's an increase. So, and in fact, it's not just mortality. If you look at DALYs, which is with disability-adjusted life years, which is really a good surrogate for burden of disease, you see that again, the burden of liver disease worldwide in different regions of the world is driven by non-alcoholic fatty liver disease. Now, of course, another type of outcome that we talk about, PROs are really important. Despite what you've heard in the past, this is not a silent disease. There's a lot of fatigue and other symptoms that patients actually could feel. In fact, from our global registry, which is on the second panel, Dr. Saeed Hamid is from Pakistan, is actually a member of this global registry in our global NASH council. You see that about 40% of patients actually have severe fatigue. These are patients with non-alcoholic fatty liver disease. And at the bottom panel, you see that when patients with NASH actually have more advanced fibrosis, that they have more impairment of quality of life. And when you model the economic burden of non-alcoholic fatty liver disease, this is from Markov models that we have published, you can see that in the United States, the cost of advanced NASH is almost $100 billion. So it's quite expensive, and that's probably true for the rest of the world. So what treatment should do ultimately is to improve long-term outcomes. And this is also related to clinical outcome, patient-reported outcome, and economic outcome. And since we cannot really measure these long-term outcomes, as I suggested, previously we used surrogates. So fibrosis, of stage of fibrosis, or resolution of steatohepatitis are surrogates for clinical outcome. And quality of life or PROs are really surrogates for patient experience. The second point of this slide is to remember that NAFLD is a part of a systemic disease. So that is associated with cardiovascular disease, renal disease, sarcopenia. And in this context, as you're using drugs to treat the liver disease related to NAFLD, that you should also improve the extrahepatic sort of outcomes. At least the drug profile should not worsen the cardiovascular profile over the other profile. But from the liver standpoint, NASH resolution or fibrosis improvement are 2 important surrogates and endpoints that have been actually accepted. Now, why actually some of these surrogates are important? And this is actually new data that was presented by Saniyal at the last liver meeting. And as you can see, this is from the Stellar 4 and Symposium clinical trials of Gilead Sciences. And when you look at the data of those patients that actually had regression of cirrhosis, you see that the liver events, liver-related events, these are decompensations, they actually were significantly improved if you had regression in yellow versus if you have no fibrosis regression. So, and when you actually look at what were predictors of this events or predictors of liver-related clinical events in patients with cirrhosis, those are how much included those that have higher stage of fibrosis at baseline, or a lot of collagen, or activation of smooth muscle antibody, or a high level of ALP. So there are some things that you can actually look at. More active fibrogenic patients at the baseline could actually potentially have a more of a clinical event if follow them over time. But this regression happens in about 16% of patients over about 48-week period of time. So important data to suggest that our surrogates may ultimately prove to be also a good surrogate for reduction in liver-related clinical events. Let's just talk about current treatment for NAFLD, and of course it has to do with weight loss, either with exercise or calorie intake reduction. There is some data with about caffeine, for example, that some caffeine intake can actually improve fibrosis. Alcohol is a very controversial area where, especially if you even actually have moderate alcohol use in the context of visceral obesity and type 2 diabetes, it actually make fibrosis probably worse. So this is going to be something that will be important to consider. But when you look at the lifestyle intervention, the study that has been published now for a few years, there are a couple of things that's really important. One, if you lose 10% body weight, you improve all histology, including fibrosis. The second important part of this is that the 10% weight loss happens in only 10% of patients. So it can actually result in great histologic improvement in NASH weight loss, but it happens actually not very frequently, 10% of patients or less. And the other, of course, issue that is also plaguing the obesity sort of management is that even if you achieve the weight loss, it's hard to sustain it over time. One of the issues for at least the United States has been what diet is the best diet. And here is, a relatively small study, 278 patients who were either obese or had dyslipidemia. They were treated with either low-fat diet, a Mediterranean diet, with or without physical activity. This is moderate physical activity. And when you look at this data, the bottom line is that if you look at the table and you look at the Mediterranean diet that was combined with moderate physical activity, that had the best impact on visceral adiposity, but also hepatic fat. So this may be at least one diet that can be considered at least then for some patients. There are a number of other drugs that have been used to treat NASH. I can tell you that there's not a lot of evidence to support them currently, and the treatment of non-alcoholic steatohepatitis. Vitamin E and pioglitazone have actually been used in the United States. It's being actually supported by ACLE guidance document. Pioglitazone for pre-diabetics and diabetics with histologically improved NASH has been shown to improve a number of histologic parameters, and we certainly use it in clinical practice. Vitamin E for non-diabetics with histologic NASH, and of course non-diabetics was that the PIVOT study that did not include diabetics is also recommended. There are some side effects to these drugs, and you just have to have a good discussion with the patient about the risks and benefits of these agents. Now, these are some of the future potential treatment options for non-alcoholic steatohepatitis, and this is not an exhaustive list. I mean, look at the targets. It's basically insulin-resistant, lipid metabolism, lipotoxicity, oxidative stress. You have inflammation as a target. You also have apoptosis and necrosis, cell death as a target, and also fibrogenesis. And there are a number of different sort of compounds that have been used. We'll look at a few of them that have been recently presented or published. This is the data from Regenerate, which is phase 3 clinical trial of obeticholic acid. It's the first drug, FXR agonist, who came into publication, and it was presented at the initial liver meeting in 2019. Looking at the 18-month interim analysis of this trial, which is a large trial and it's ongoing because it's an outcome study. But the interim analysis was based on histology. And when you look at the three arms of the study, placebo, OCA 10 milligram, OCA 25 milligram, you see that at least in this study, that OCA 25 milligram had met the primary endpoint of the study, which was improvement of fibrosis by one stage without worsening of steatohepatitis. Now, there was an alternative second endpoint that was also looked at, that was resolution of steatohepatitis. That wasn't met by this in the study. However, if you look at the components of steatohepatitis, and almost all of them improved. Side effects in general were mild. It was across the three arms was balanced. The two side effects that needs to be discussed was pruritus, more common in patients with OCA 25 milligram. However, these were mild, and then generally speaking, didn't really impact patients' quality of life. LDL increases happened and was experienced by first month, but it was managed with statins. And in fact, at the end of the treatment, or at the end of the 18 months, those patients who were treated with statin either reached their baseline or actually even improved their dyslipidemia. So this was actually the initial data that was presented to Regenerate. Now, in the Regenerate, the data, the 18-month data was initially presented for patients with stage 2 and 3 NASH, with stage 2 and 3 fibrosis. Now, there was also a group of patients that had stage 1 fibrosis with some risks. So in this expanded sort of part of the trial that was presented at the Easel meeting over the summer, it was shown that not only the fibrosis improvement with 25 milligram arm is met, but also steatohepatitis improvement is now can be clearly shown vis-a-vis placebo. There are a number of non-invasive tests that you heard about today from our colleagues. Again, this was a assessment of fast tests over time, and as you can see, that there was actually improvement of these non-invasive tests, especially with the 25 milligram arm of obeticholic acid. And finally, this is an interesting data that was also presented at this last Easel meeting. And as you can see, that when you actually take the efficacy using NITs here was FIB4 and Elastography past month 18 to month 24, you see that not only did that improvement actually was maintained, but actually continued and for some of these patients. So this drug, of course, is now being considered for approval in the United States as well as in Europe, and will probably be one of the first drugs that will potentially be available for our patients. Now, let me show you some other drugs. This is phase 3 clinical trial of elafibranor, which was a dual PPAR agonist. Quite interesting study in Golden that was initially presented and suggested that resolution of NASH happens with patients who were treated with elafibranor, 120 milligram, and this is the phase 3 clinical trial, Resolve It. The data was presented at the PSSLD meeting just a couple of weeks ago. Unfortunately, primary endpoint of the study, which was NASH resolution without worsening of fibrosis, or the key secondary endpoint of fibrosis improvement by at least one stage, was not met. And because of not even seeing some histological improvement in these patients, this monotherapy with elafibranor has been abandoned as of now. Another very promising drug that was actually presented again a few weeks back at the AASLD, or American Association of Liver Disease meeting, semaglutide, which is one of the newer GLP-1 agonists, receptor agonists. This is the study that looked at the phase 2 study, looking at 3 different doses of semaglutide in patients with stage 2 and 3 fibrosis, and of course, histologically proven NASH for 72 weeks. And the data suggested that when you look at NASH resolution, there was an incredibly impressive improvement of steatohepatitis. Over 55% of patients actually improved or resolved steatohepatitis without worsening NASH. When you look at the second endpoint, which was improvement of fibrosis, the 0.4 milligram had actually numerically higher numbers, but the placebo rate was very high, and that was not significant. You look at body weight loss, you would expect semaglutide to improve that. Of course, you see that here, and 12.5% body weight loss with the higher dose, the 0.4 milligram dose. And then, of course, hemoglobin A1C was also improved. And the side effect profile is expected with GLP-1 receptor agonists, which is mostly GI side effects. So this drug, of course, is promising and is probably going to go pretty soon for phase 3 clinical trial, probably in a number of different countries. Another drug that seems to be promising is the NGM-282 by NGM Pharmaceuticals. There has been phase 2 data presented in the past. This was the 24-week randomized double-blind placebo-controlled multi-center study of aldafermin, the NGM-282. The bottom line of this study is that when you look at the MRI PDFF in terms of fat, or if you look at biopsy, those improvement with active arm, both in terms of histology as well as in terms of the fat content. And when you look at surrogates like ALT, AST, or even ProC3, which is a fibrosis marker, there was improvement. There was not a lot of safety issues, so this drug hopefully will also go into phase 3 clinical trial. Another sort of class of drugs are the thyroid receptor beta agonists for treatment of non-alcoholic steatohepatitis. Resmetirom is one of them, and this was a phase 2 clinical trial that was presented some time back, but in fact showed that both ALT as well as the MRI-PDFF improved. And for some of these patients, there was just some histology available, and there was some improvement in histology. And the last ASLD meeting, just a couple of weeks ago, again, resmetirom in phase 3, the Castera NAFLD 1 trial, some of the data was presented. And as you can see here, MRI-PDFF, MRE, improved in this study, and a number of biomarkers were looked at. So this seems to be another promising drug, and it's going into phase 3 clinical trial for treatment of patients with NASH. And another drug in the same family is VK2809, which is from a company called Viking. It's a novel liver-related directed thyroid receptor agonist, beta agonist in NAFLD, and this was presented during the Easel meeting this year during the summer. 4 different sort of arm of the study are depicted here. When you look at the fat reduction by MRI-PDFF, 12 weeks, you see that actually all doses actually achieved that improvement of fat. And when you continued this for 4 weeks post-treatment, at week 16, at least the 5 milligram arm maintained actually actually both 5 milligram, or actually when you look at the combination of all different regimens, maintained that improvement. So this would be another potentially interesting drug. Finally, I personally believe that the future treatment of NASH required combination. This was a great combination that was actually looked at and was presented at the last liver meeting. This combination was either semaglutide alone or semaglutide with a couple of other drugs from Gilead scientists, firsocostat and cilofexor, were the 2 drugs. And as you can see, for the treatment, you look at the MRI-PDFF impact, and you look at semaglutide with FIR. Probably that one has the best reduction in fat. In terms of side effects, and in fact, when you look at the table, there are a number of non-invasive tests, including ALT tests and ALT, and there's again some significant improvement. Side effect profile is sort of known for semaglutide as GI side effect, and there's minimal pruritus, related to silo, and then so that really is a proof of concept study to allow us to look at the combination of multiple drugs, and probably with semaglutide and others that are going to come down the pike, and this combination probably will be the future treatment. So to summarize, what I hope to share with you is that NASH and its complications are growing globally, and it's important to remember that NASH is a part of multi-systemic disease, metabolic diseases, including cardiovascular disease and non-hepatic cancers. Stage of fibrosis, an important predictor of long-term outcome, mortality. Patient-reported outcome and quality of life is impacted. There are a number of fibrosis in ITs that are being developed. There is one called ALT test that we talked about. There are others that are going to be will be available. Elastography is, of course, another non-invasive test. Treatment of NAFLD and NASH requires a multidisciplinary. This is one disease that you not only will have hepatologists and gastroenterologists involved, but also diabetes experts, nutrition experts, and exercise experts will be involved. And primary care will have an incredibly important role, because they are going to really want to see most of these patients. So how to involve them will be very important in the context of COVID, that we are using telemedicine for everything, including this annual meeting, the virtual meeting that we have currently. I think telemedicine and virtual meetings would be something that we can do in the future. So in the clinic, you need to use algorithms, and especially NITs, to risk stratify these patients. And then lifestyle intervention, of course, for all patients, because you want to improve their metabolic risk. For some patients with morbid obesity or very extreme obesity, that they can be candidate for bariatric surgery, that may be an option. Currently in the United States, we have vitamin E and pioglitazone, but there are a number of different regimens that are going to be available, and hopefully we will have more options for our patients. So I want to thank you for your attention, and hopefully we can have some questions during question and answer.
Thank you very much, Professor Younossi. Indeed, it was a great talk. So may we have all speakers to share your webcam? Good. So nice to see you all again. So I think we can start from our chairs, and so the burning question I would like to throw again. So Dr. Ajay's talk was like so convincing about not again to redefine NAFLD as MAFLD. So let's see what is the perspective of our other speakers and chairs. So we may start from Professor Younossi about his perspective. Should we redefine NAFLD as MAFLD or not?
No, I agree with, can you hear me okay?
Yeah, we can hear you.
Okay. No, I agree with AJ completely. I think we wrote actually two different editorial, one in hepatology and one in general hepatology. The issue is not about the name. The issue is that what a change in the name is going to ultimately do. I think at this point, the change in the name is going to do more harm than good. I understand that NAFLD is not a perfect name, and it probably will be changed. But that's one thing that the harm that's going to come to the field in terms of drug development, patient awareness, policy sort of issues, there is going to be more damage. And in this context, in fact, there is actually now, I was in a meeting yesterday, I don't know what Laurent was there or not, but I think there is an effort by PSSLD, Easel, Apollo, and also a number of other societies to do this assessment. Do we need to change in the name? Go through actually an evidence approach for both pros and cons, and at the end decide if there is a need in the change of the name or not. That's going to happen over the next at least year or so, led by our major societies. That will include patient advocacy groups, probably some industry as well. So we're looking forward to that. But at the moment, everyone has decided, major journals, that MAFLD is not a term that should be used. At least I can tell you this from hepatology. And I think Journal of Hepatology has decided the same thing, that we will wait until we have input from everyone before we make the change.
Thank you. So, Professor Jasmohan Bajaj, would you agree with our two other speakers, or you have a different perspective? What do you think about this?
No, I totally agree. I think the more stakeholders you take into account, and not just the practitioners, but the patients who often face the stigma of alcohol being involved somewhere. And I think that's the push. It took a long time for us to change from primary biliary cirrhosis to primary biliary cholangitis. Yeah. And a lot of that was despite the patients being labeled cirrhosis. So I think the more systematic we are, the more inclusive we are, the better off it is going to be for us. And I'm fine with the way things are right now.
Can you hear me?
Yeah, we can hear you.
Yes, now basically I echo what has been said before. Of course, the nice thing with the PBC change is the acronym has not changed. And of course, make it easier. Now, like Zobair mentioned, I think, of course, this needs to be endorsed by professional medical organization and patient association as well. Otherwise, it will be very confusing. Also, in terms of awareness outside our field, I think we have to be careful because, as you know, the level of awareness regarding NASH, NAFLD, whatever, MAFLD is very low. And so if we're changing the term, this might add even more confusion. So I think we have to be aware about this.
So there was a comment in chat box from Professor Robert Gish that in the world of democracy we can vote. So when the discussion was going on about MAFLD and NAFLD, I think the comment was related to that. So far, like all speakers actually agreed that this is not the right time to redefine it. So our another chair, Professor Khurram Bakai, has a question for Dr. Laurent Castera.
My question to Dr. Laurent Castera. I'm Dr. Khurram Bakai. Thanks for your wonderful presentation. We do lots of scoring systems, evaluation, assessment. We do rule out the diagnosis, other diagnosis in patients who have NAFLD. So it raises the issues of cost effectiveness. It gives a lot of cost to the patient. So can we take some steps to minimize this cost?
Sorry, I did not get the question because there was a lot of noise on the line, so I could not hear the question.
I will repeat. We apply a lot of scoring system to the patient. We assess the patient. We regularly evaluate the patient. We rule out the other diagnosis as well in patients with NAFLD. So it raises the issue of cost effectiveness. So can we take some steps to minimize this cost?
So his question is cost incurred in doing non-invasive testing while we are evaluating patients and we are monitoring at the various stage of their treatment doesn't look like cost effective, especially where the biochemical or some other testings are involved in the various non-invasive scoring system. So what do you think? On the other hand, the liver biopsy is invasive, but this is one-time test which actually give you more insight about the stage of the disease and some more information, diagnostic information as well. So in terms of cost effectiveness, where do you see these non-invasive tests as like initial evaluation and the monitoring of the disease? Is this your question, Dr. Khurram? This is his question.
Okay, I got your point. So, of course, cost effectiveness is a very important issue if we want to extend the use of these non-invasive tests. And basically what I've shown in my talk is that the tools are pretty well validated. They're widely available. Then, of course, it depends which population you're targeting, whether you want to screen patients in primary care or do some monitoring of treatment in trials, which are very different aims and goals. And for screening large population, of course, cost effectiveness is important because you will have to convince the payers in every country that this is a cost-effective strategy. So actually, we have published recently a paper in GF showing that transient elastography was effective in large population. The first author is Burrell, and I encourage you to read it because there are not much literature actually on cost effectiveness of non-invasive tests. But again, as I mentioned, context of use is critical when using non-invasive tests. And for instance, if you are to screen a large population, of course, you're not going to use transient elastography so far. You will rather use FIB4 or NAFLD fibrosis score, and actually FIB4 is probably the most suited test because it's the simplest one, and it comes for free. So it's more now a matter of awareness, I think, because most GP have no clue what FIB4 is, or even many diabetologists, they don't know. So outside of our specialty, the level of awareness of all these tests is very low. And I think this has to come also with cost effectiveness issue to show that given the magnitude of the problem with NAFLD, this is a very important point.
Professor, if I can just add one point. There is actually a study that was presented at the last liver meeting by Mazen Noureddin from Cedars-Sinai, which was a cost effectiveness study of exactly what Laurent was talking about. In fact, in that study, it's a model, it's a cost effective model. That the approach that Laurent is talking about is cost effective.
Professor Castera, okay, Ajay.
Yeah, I just wanted to make a point, and maybe Dr. Castera maybe can comment on this. I think the other issue with non-invasive testing is about that these tests may be applicable to a particular population, and the cutoffs may differ from groups to groups or to population to population. For example, from India, we have now looking at our fast cutoffs, and we found that our cutoffs were different from which were originally shown by the study from UK. Similarly, the FIB4 cutoffs from India have shown that I think the lower cutoffs in our population and the kind of population you are studying would be different. So any comments on this? Are these dependent on the population, and how do we,
May I add something, Ajay? There are some studies that show that cutoffs maybe age related. Like the age, if your age is less than 50 or 55, then your cutoff would be different as compared to the age more than 55 and then more than 65. So here question arises, what cutoff should we, when we are educating our primary care physicians, what cutoff should provide them? What should be the particular cutoff? Should this be a single figure, single cutoff, or there should be some differences, age-related differences in cutoff also?
So this is a very important issue. I think the cutoff is related to the population, but is mainly related actually to the prevalence, so the pre-test probability in your population. And we know that in primary care, usually NAFLD is highly prevalent, so 25 to 30%, even more in some countries. But advanced fibrosis is less than 5%, whereas in secondary care or in tertiary referral center, it's usually 20, 25, 30%. So this, of course, going to influence, and what you're trying to achieve when using FIB4, for instance, in the general population, is to have high negative predictive value, because we know that by nature, positive predictive value will be low. So far, there have been different cutoff proposed, including in viral hepatitis, because as you know, this test has been initially proposed in HIV, HCV co-infection. And the cutoff that usually people recommend is 1.3. Then, of course, there is the issue of this dual strategy, this dual cutoff strategy, because the upper cutoff may vary according to the age, because age is part of the FIB4. And some authors have proposed to adapt the cutoff to age. In my opinion, actually, if you're addressing GPs, if you come with two cutoffs, it will be very confusing for them. And I think you need to come with a single cutoff. And what we are trying to achieve, actually, is to rule out the majority of patients without advanced fibrosis that do not need to be referred to the specialist. On the other hand, if you're above 1.3, I think we have to assume there will be a little bit of over-referral, because some of the patients will be in between the two cutoffs. And in this patient, of course, I think with the second test, whether it's ELF according to your local availability or transient elastography, you will probably be able to solve this issue. And then the upper cutoff is not really an issue, because in any cases, you will have the transient elastography and the liver stiffness to solve the issue. So I think the most important message is below 1.3, we don't need to see these patients.
Yeah, and I think this is where the cross-section between public health as well as our hepatology referral comes into place. So in the VA, where I work at the Veterans Hospital, which employs more than 260 hospitals across the US, we usually use a cutoff of FIB4. And of course, as you said, we use it in people who are less than 65, because above 65, it's usually. So again, a local context and the ability to actually over versus underdiagnose, it's different for every population. And therefore, I hesitate for a one age or one size fits all. So if you have, say, suppose a website which you can plug in things and that spits out a number, however flawed versus whatever, you just draw a line in the sand, that actually is, which suits your patient, that might be better. So a FIB4 or something like that, that can be done as population perspective, and then focused on things, as you said, with transient elastography. Once you have, people at least, if not 1.3, then 2.67 or higher, that would get more advanced fibrosis patients.
My one question to Dr. Bajaj and maybe Dr. Younossi also. Just you mentioned in your presentation about the choline, and we know in the experimental rodent model, choline and methionine deficiency diet is given to rodents to induce fatty change in the liver. So what do you feel like, is there any place of choline and methionine as a therapy for the patients with non-alcoholic fatty liver disease?
I'm not familiar of people actually studying that specifically as a treatment. It's actually quite abundant in people who eat eggs and meat. So choline is actually very abundant in the population. Zobair, are you familiar with any?
No, any specific diet that enrich choline and methionine, I don't know of any. But I think, as you said, it'd be very hard to have that kind of a diet and for human studies. And so I'm not sure it'll be done in the future.
Another question to Professor Younossi. The obeticholic acid and L-diffamine, they have very similar mode of action through the FXR receptors, or maybe at the level of liver is concerned. So what do you feel like that any one of these will be have edge over the other as far as the efficacy and side effects are concerned?
Well, I think the main issue would be, do we have good data? I mean, at the end of the day, there's a lot of great drugs that showed good efficacy in phase 2 clinical trial. I'll remind you of a drug that was called, that was an ASK1 inhibitor. It was called Solonsertep. It was a drug that was developed by Gilead Sciences. In fact, when you look at the mechanism, and again, it was supposed to be, anti-apoptotic drug, meaning apoptosis being actually looked at in liver biopsy, at least partly through ballooning. So it should have worked very well. And in fact, in the cell culture model, in the animal model, it worked extremely well. And when in phase 2 clinical trial, it didn't work. Well, it worked, but then in phase 3 clinical trial, it didn't work at all. So the only drug that has shown efficacy right now in phase 2 and phase 3 clinical trial right now is obeticholic acid. Aldafermin, I think, is actually an interesting drug, and in phase 2, as I showed the data, does seem to work. The question is, what happens when you do phase 3 clinical trials? So I think comparing the two drugs would be very difficult without really head-to-head randomized clinical trial. The last thing I would say is that the drug both probably will have some advantages and disadvantages. In aldafermin's route of delivery is going to be a challenge, which is injectable. But on the other hand, if you combine it with another drug that's injectable, I'll just give an example. Semaglutide is also injectable. And I actually am very positive about GLP-1s in general. So if you combine two different mechanism drugs that will actually give that hit different pathways that Ajay was talking about in the pathogenesis of NASH, maybe that would be better. So at this point, I think it's unfair to say, is obeticholic acid better than aldafermin? I can tell you that obeticholic acid, despite the relatively lower efficacy, the 27% efficacy, still is the only drug that has shown efficacy in phase 3 clinical trial and is being considered seriously for approval.
So we have a few questions from audience. So the one question is for Professor Younossi. What is the prognosis of non-alcoholic fatty liver disease related cirrhosis after transplantation, especially the people who have underlying metabolic metabolic syndrome?
Very important question. There was actually some initial data suggesting that they will have poorer survival. That has not been the case. We looked at this data with Younossi database, which is the United States database for transplantation, and in fact, there was no difference between NAFLD or NASH related transplantation versus other types of transplants for other indications. Now, there is going to be more component of metabolic syndrome, of course. Some of it because people were predisposed to that, and others are actually driven by the anti-rejection medication that can induce it. But in general, at least in the sort of medium term, now we don't have very, very long-term data of 10, 15, 20 years, but medium term, 3 to 5 years, the outcome seems to be similar. That's really why that there is no issue in terms of placing a patient for liver transplantation in the United States with diagnosis of NASH cirrhosis.
Okay. So another question is the role of saroglitazar in the management of non-alcoholic fatty liver disease.
Now, I omitted to talk about cytoglitazole, knowing that AJ is going to be on this panel. The reason is that we don't have that data, at least in the United States, in a randomized clinical trial. I know it's going to come down at some point, but I know it's actually approved in India, and I've been in a lot of panels with my friends from India, including AJ. So maybe AJ can actually answer that question. It seems to be quite interesting, and it seems that the mechanism works well, but I think in terms of the specific data, AJ can actually provide that answer better than I can.
Okay, Professor Ajay.
Yeah, I think about the saroglitazar, I think as said, I think this has been approved in India by our Drug Controller General of India. So the approval came based on two studies. One was the phase 2 study, which was presented in 2019 ASLD, and this was the Evidences 4 study, and the other was the Evidences 2 study, which was done in India, which was a small number, but this was a histology-based data, and where the histological improvement endpoint was the improvement in NAS score by 2 or more points, and that was more than double, around 52% in the drug arm versus 23% in the placebo arm. So based on that, the saroglitazar has been approved in India. But then, other than these two studies, I think there's a lot of real-life data which is available from our country, maybe around 6,000 or 10,000 patients, and this drug is in the market for diabetic dyslipidemia for more than 8 years or 10 years. I think good safety profile, very good biochemical response, causes reduction in inflammation. The only issue is about its role in hepatic fibrosis, which needs to be studied more. Otherwise, looks a very good drug, promising drug, but I'm sure that I think US probably was starting a phase 3 study on saroglitazar, I think, and the things would be more clearer. So I had a question again for Professor Younossi, if you can permit.
Yeah, sure.
This is regarding the combination treatment, which you rightly said may be the future. And I think the only point or the comment I wanted to make on this was the recent data on Atlas trial, which was published in Hepatology. I think the added advantage of combination, in addition to the increased efficacy, would be that in there they could reduce the dose of cilofexor to the extent that the side effect of pruritus actually came down. If you look at the data of pruritus in Regenerate close to 50%, this was only, I think, 20% or something in the Atlas trial because they reduced the dose of cilofexor. So I think the side effect profile would also probably be better with combination in addition to the efficacy. Your take on that?
No, I completely agree. I think there are really three reasons, in my view, that combination would be important. Number one, I don't actually believe that treatment of NASH would be a 6 months or a year treatment. We're going to treat NASH like diabetes, not like hepatitis C. So it's going to be a treatment that will be lifelong. In that context, I think you need to have what I call an induction regimen, where you actually combine multiple drugs of different sort of targets to maximize efficacy and really minimize safety and side effect profile, as you suggested. But then after that, you need to then take one of those drugs, and maybe in a lower dose, to continue in terms of maintenance. So that's sort of what I actually think. You're absolutely right. Now, the Atlas, of course, trial, I didn't show this because of limitation of time. None of them actually, even the semaglutide combination with silo and Sierra, didn't really show efficacy on phase 2 clinical trial. But it was really, in my view, proof of concept. The future, I think, combinations would be combinations that are really very carefully selected for exactly what you said, maximize efficacy and minimize side effects.
Thank you. So the last question for Professor Jasmohan Bajaj. So the lean NAFLD is a challenging area in terms of management, and especially when they don't have any underlying risk factors which are the component of metabolic syndrome. So what is your perspective about the role of microbiota in patients with lean NAFLD, and any comment about how to manage these patients?
So I come from the land of plenty. We have very few lean NASH in US, although in my origin country where Ajay is right now, we have plenty of lean NASH. I did collaborate with people from Korea where they have a lot of lean NASH, and their microbiota it does tend to be very different with the changes in bile acids in them as well. So this might be one of the ways, but clearly this is, as everyone has been pointing out here, we are all looking at different threads of a multifaceted disorder. And again, looking at the combination, microbial therapy, microbial diagnosis, microbial therapeutics are all one component of many other things that need to happen in these patients. Now, from a pathophysiological basis, it is quite likely that lean NASH patients have a different kind of microbiota, not just the structure, but the function of that microbiota that promotes this from happening despite huge amounts of metabolic syndrome. But is that enough? Is that the only reason? I don't think so.
Let me just make one comment. I know you're running out of time. I think it's very important that we actually define what lean means. So a lot of studies looked at body mass index, which is not the right way to actually define lean. You have to look at both body mass index and visceral obesity to define it. That's number one. And number two, when you're talking about really lean, you have to think about, is it actually a metabolically healthy lean or metabolically abnormal lean? Those are different people. Those are different actually pathogenesis that they will have. I agree that dysbiosis, as Jas was just talking about, probably is very important. And really metabolically healthy lean patients in some ways, that may be the predominant pathogenesis. But in metabolically unhealthy lean patients, then it may be very similar to what we see in the West. So I just wanted to make that point, and I know you're running out of time. Thank you.
Thank you very much. This was again a very, very, very important point you have highlighted. So a wonderful session and extremely, I would say that exciting talks. We all enjoyed the comprehensive discussion again in the end. So I would like to pay my gratitude and thanks to Professor Ajay Duseja, Professor Laurent Castera, Professor Ajay Saniyal. Because of some personal reasons, he couldn't join us during question and answer sessions. But thank you very much, Professor Saniyal and Professor Jasmohan Bajaj and Professor Younossi, and our chair, Dr. Bakai, Dr. Nasir Lak, and Professor Zagham Abbas. So thank you very much for supporting PSSLD, and which was a great experience. Thank you very much. So
thank you. Thank you very much.
Thank you. Okay.
Thank you.
So bye. So, ladies and gentlemen, here we are ending our day, which was pretty long, but we will be back tomorrow with a Rising Star Symposium. And the day will be full of like other 4 or 5 exciting events, including the closing ceremony. So we'll be having a session about liver transplantation, autoimmune diseases, liver tumors, and a potpourri session, and then the closing ceremony. And in closing ceremony, the winners of the quiz, the winners of the best oral presentation, best poster presentations will be announced. So see you tomorrow, inshallah.